Hello and welcome. You found the Social Work Podcast. My name's Jonathan Singer, and I'll be your host as we explore all things social work. Hey there, podcast listener. Jonathan here. In today's episode of the Social Work Podcast, you and I are going to tackle the question, can healthcare make suicide a never event? Are there things that healthcare systems and the people who work in those systems, like social workers, counselors, nurses, doctors, psychologists, you know the list. Are there things that can be done so that suicides don't happen? I hear what you're thinking. Yeah, sure, we can do better, but, some suicides are inevitable. I mean, at the end of the day, if somebody really wants to kill themselves, they'll do it. Well, that's what I was taught. But I just want you to hold on to that thought for a while. We'll come back to it. So why should healthcare tackle the issue of suicide head on? Here are some stats. According to the World Health Organization, over 800,000 people die to suicide every year. In the United States, suicide is the second leading cause of death among Americans aged 10 to 34. Now, it used to be homicide, but now it's suicide. That's right. During the healthiest years of life, Americans are more likely to kill themselves than be killed by someone else. So, wait. Well, that's the answer, right? Healthy people don't go to the doctor, so healthcare systems can't tackle the issue. Done. Okay. Episode's over. Bye. Just kidding. It's not really as simple as that. So, yes, if we want to reduce global suicide deaths from 800,000 per year to zero, we'll have to tackle way more than just healthcare systems. And in the U.S., there are lots of groups of people who don't trust healthcare systems. African Americans are more likely to turn to religious leaders than healthcare professionals, in part because they've been abused and neglected by the healthcare industry for hundreds of years. People who have migrated to the United States can't get what they need because of language barriers and sort of different definitions of what constitutes a problem and therefore what constitutes a solution. And white people living in rural areas might not have language or cultural or historical barriers, but life in small communities can make confidentiality more difficult, so they don't want to go to their provider. And when it comes to suicide, for all groups, the struggle with shame and silence is real. But people across the lifespan see healthcare providers, and people across the lifespan die by suicide. Any effort to reduce suicide has to include healthcare systems. A 2015 study by Ahmadani and colleagues looked at suicide attempts in U.S. healthcare systems, and they found that nearly 65% of people who made a suicide attempt had seen their doctor within the last month, and nearly 40% saw their doctor the week before they tried to kill themselves. So what would need to change in healthcare so that those 65% were identified, that appropriate care was provided, and that the suicide attempt was prevented? And for those in studies other than Ahmadani's that actually looked at suicide deaths, what would need to happen so that the suicides were prevented? Well, as my guest David Covington explains, there would need to be changes at the individual, provider, and systemic levels. And the first change is that individual providers and healthcare systems would need to believe that suicides are preventable. In other words, they would all need to agree on the goal of zero suicide. So, why should social workers care about zero suicide? Well, zero suicide fits social work values. Zero suicide can only happen in a culture where people are encouraged to reach for the moon, that is, no suicide, but are not punished for falling short. And this is an idea that's referred to as just culture. And you'll hear David talk about it, and it comes from the Henry Ford Health System's Perfect Depression Care Initiative. So zero suicide can't happen without social workers, right? Social workers provide more mental health services than all other professions combined. Social workers are team players, and zero suicide is inherently interprofessional. Social workers are advocates. And what if healthcare organizations use best practices, but those best practices haven't been developed with diverse racial and ethnic groups, or don't take into account complex medical or trauma histories? What if zero suicide means that healthcare organizations have to spend more on training and staffing? And who's going to advocate for consumers if those costs are then passed along to consumers rather than investors? Social workers have a professional responsibility to be involved in those conversations. Social workers are trained to identify and respond to issues at the practice, that's the micro, and the policy, that's the macro level. And well, guess what? Zero suicide is like the holy grail of micro-macro integration. It requires coordinated changes in values, beliefs, and practices at the provider and system level. And David's also going to talk more about this during the interview, but in plain English, what this means is that as a social worker, I have to believe that suicide is preventable, know how to assess, intervene, and coordinate care, and trust that my organization will have my back. At a systems level, healthcare organizations have to make a multi-year commitment of time and resources to reduce suicide deaths, train and support clinical and non-clinical staff, screen and assess everyone in the system, and use data-driven quality improvement. And it can't work without changes at the micro and macro level. In today's episode, I spoke with David Covington, LPC, MBA, who, along with Mike Hogan, developed the Zero Suicide Initiative. We talked about how David went from clinician to healthcare executive, from running a crisis service to organizing zero suicide initiatives around the world. We talked about what zero suicide means for providers and healthcare leaders, and ended with information about how you can get your healthcare organization involved in zero suicide. Now, we're about to hear the interview, but first, I'd like to ask you 3 things. And no, I'm not asking you for money. First, I know that there are tens of thousands of people who listen to the podcast, but I don't actually know much about you. So I'd be really grateful if you could take a minute to fill out an audience survey. And you can find the link to the survey in the info section of this episode, and I put it on the top right corner of the Social Work Podcast website at socialworkpodcast.com. The second thing is, if you like what you hear, leave a review on iTunes. The more reviews, the easier it is for folks to find the podcast. Finally, I've had several requests for transcripts, and I'd love to be able to provide transcripts for every episode. If you have an interest in transcribing an episode in exchange for a shout-out in the next episode, send me an email, jonathan.b.singer@gmail.com. And now, without further ado, on to episode 106 of the Social Work Podcast, A Zero Suicide World, an interview with David Covington. David, thanks so much for being here on the podcast and talking with us today about zero suicide. So what got you passionate about suicide and about this idea of zero suicide?
Thank you, Jonathan. You know, my very first experience was back in 1995, and it was the week I was graduating with my community agency counseling degree. I had gone through, it took me 4 years to complete that degree. I was working part-time. It was a 60-hour CACREP accredited program at the University of Memphis. And that Saturday, I took the 4-hour National Counselor exam, which they were using as the exit for licensed professional counselors. And I came out of that exam that Saturday really on top of the world. I was a master counselor because I had just, I was about to graduate and thought I knew what I needed to know. And it had great training. And I walked into our townhouse, and my wife at the time handed me the phone. As I walked in, tears are running down her face. And she had just received a call from someone who I didn't really know that well, who was a church member. And he was calling anyone, just to say goodbye. So the very first thought that went through my mind was not, what can I do to help this individual? The very first thought was, are you kidding me? I just spent 4 years through multiple videotapes, practicums, internships, all kinds of great training, but not even 5 minutes of preparation for this moment. And I spent the next 10 hours trying to figure out, what in the world do I do? I didn't know where this individual lived. There was some good, there was some bad, there was some ugly that went on during that next 10 hours. I relied on the collaboration and engagement, the good things that I had been trained. So there were some things that I think I did well. A few hours later, law enforcement was outside the Walmart in Jackson, Tennessee, and the individual and myself were in the McDonald's portion of that Walmart in the back. And later, law enforcement asked me if it was such a great idea to get the guy. He had a shotgun and he was wanting to shoot himself. If it was such a great idea to get the guy with the firearm to go to a public place. So that probably wasn't my greatest moment. But the individual, the pastor's wife was pushing her shopping cart around the Walmart pretending like she was a customer. I had law enforcement outside. And it was trying to persuade this individual to get an assessment. And he agreed to go out, and once he understood law enforcement was outside, he agreed to go in for an inpatient evaluation if I would go with him. And so we went in. The psychiatrist, this was, I think, a great thing. This is 21 years ago. He said, look, David, I'm willing to admit this person, but I'm going to need you to go out and secure the shotgun so that when he's ready to be discharged, that weapon won't be in play. So I had to go find this weapon. So I get home at 5, 6 in the morning. None of that partying, that I mentioned was going to happen. And, years later, when I'm responsible for managing programs with literally thousands of clinicians underneath our responsibility, I realized that their preparation and training really wasn't that much better than mine had been when I first ran into to that moment.
So you had just graduated, you were a master level provider, and you really got thrown into the fire. It sounded like it really disrupted your sense of, I know what I'm doing.
Immediately, right? So it was the real final exam, but I had not been prepared for the questions and had to kind of make it up as I went along. And, I'm not saying that I didn't have great training, but I didn't have training for this issue. Richard McKeon, who's the branch chief for suicide prevention at SAMHSA, years later in one of our meetings, which really formed the platform for zero suicide, made a statement that has really gone with me. And he said that over the decades, individual clinicians have made heroic efforts to save lives, but systems of care have done very little. I'm not sure they've done anything. And so that's ultimately where I found an opportunity is that clinicians could be better equipped, and they would be within the learning environment of an organization to help them do what they love and do it better.
So how did you go from this individual clinician experience to thinking system-wide, to thinking zero suicide as a systemic thing? Yes.
There really were some intermediate steps for us. In 2009, I was the CEO of a crisis services company in the state of Georgia, and with the recession, the Great Recession that was hitting, I wasn't really clear where everything was going. And I landed up interviewing for and receiving a job at Magellan Health in Phoenix, Arizona. And we were responsible for the health plan contract with the state of Arizona, Medicaid, and the Department of Health. It was a $750 million a year contract, responsible for about 100,000 people receiving active services. Underneath that was a network of providers with about 7,000 to 10,000 clinicians, social workers, counselors, physicians, etc. And when I came to that program, the CEO of that contract went home one weekend, and he had about 8 records that he was reviewing to understand better the risk management, the compliance, the quality review process. He came in on Monday morning just distraught because for all but one of those, they were young men between the ages of 25 and 35 who had died by suicide. And their risk was known to the system. There was nothing in the charts that would suggest way out of practice kinds of activities going on, and yet this is the the worst outcome possible. And he challenged our team to begin to take this issue on in a way that it had not been taken on. The first thing I did was pull together a focus group of about 70 professionals and asked them some very basic questions. Several questions that were just sort of cultural statistics about suicide, that kind of thing. But the key questions I was looking for were, what was their self-report of their preparedness? Again, thinking back to this experience of when I didn't know what to do. Just on a Likert scale, how would you report that you were trained? Where are your skills? The thing that came out of that day that I will never forget is the frustration and anger from many in that group. They wanted another question. They wanted a question about the support and supervision of their organization to do this work. And I determined that we needed more data. So we landed up doing a Survey Monkey style approach. We had about 1,700 responses to that first survey. And subsequently, we just kept doing the survey. We redid it after a year in Arizona, but I had relationships in other states, and we began to repeat it. We ultimately have done that survey in 9 states and had over 30,000 people participate. We've done a couple of published papers with researchers out of Dr. Thomas Joyner's group at Florida State. And the bottom line sort of finding of that survey is that for professionals, clinicians, social workers, counselors, psychiatric nurses, for them, there's about a coin toss chance that they will at least agree to 3 questions. I have the skills to engage those at risk, I have the training, and I have the supports and supervision. So, imagine going in for a heart procedure or a cancer treatment and your physician saying, wow, I haven't done this before, I'm not really trained for it, I don't have the skills, but let's give it our best shot. Now that data, while not surprising, it fit with my own experience. It fit with the other clinicians that we had seen. And the one other question we asked was, have you had someone under your care, under your responsibility, on your caseload, die by suicide? For that nationwide survey, it was 27%. It did differ a little bit by state because of the differences in rates by state. But about half of that group said that it happened to them more than once. And during that process, we looked into and there's a small amount of research about the impact upon clinicians when someone dies by suicide. We clinicians are not robots, we're human beings, and about a third have a very acute reaction, like we would have for a coworker or a friend or loved one. And a small percentage leave the workforce. They decide, I'm going to do something else. So that was really a core impetus for us to do something really different. The other thing, so there was a very significant portion of our effort that was about the clinicians, the staff who do this work day to day. We also realized that a very significant number of people with serious mental illness were dying by suicide. In 2010, the National Action Alliance for Suicide Prevention was formed, and they launched a number of task forces for high-risk groups, veterans and military, LGBT youth, Native Americans, American Indians, and older white males, all groups that are at elevated risk in comparison with the general population. But in our work, what we discovered is the relative risk, or the hazard ratio, if you will, for people with serious mental illness, schizophrenia, bipolar disorder, major depression, is you almost have to stack those 4 other groups I just mentioned together to achieve the same rate of risk. And healthcare systems have just not focused on these individuals in that way. Now, I was working in a $3 billion company at the time. I was very cautious and thoughtful about how we proceeded with this initiative because we were really trying to do something very different. There was a hypothesis among some executive staff about an increased focus on suicide would yield higher inpatient admissions and thereby a higher medical loss ratio. We were going to run into trouble from an expense standpoint. But others of us on the team had a different hypothesis, and that was with a clinical workforce who is afraid of this issue. I'll give you one example. We had a social worker who she had a team of 10 underneath her, paraprofessionals, peer support staff. And the physician came in to her team and said, look, I need you guys to really get down in the hole of pain with a person before you just come to me and look for them to be admitted. And I'm going to give you some guidance on that. Now, I don't know what happened to the paraprofessionals on her team, but I know what happened to her. She went to Human Resources 2 weeks later and said, I can't eat. I'm not sleeping. He has placed this burden on me that I don't want, and I'm not prepared for it. So we had the hypothesis that if we equipped a workforce, that we would actually see reductions in costs. We'd see safer and more effective care. And we thought there would be cascading effects of if we can get to the heart of what clinical staff do and help them to feel confident, competent, and their caring can really come out, then we were going to get all kinds of benefits. And this is way before we began thinking of the word zero.
So you're talking about identifying gaps in provider knowledge, their confidence, all that sort of stuff. And at the same time, there is the issue of, well, how much is this going to cost? And I know a perpetual question for providers is, are these decisions made by insurance companies really about patient care, or are they about the bottom line?
My basic responsibility was, is the care safe? Is it effective, and is it cost efficient? And we had to address all three of those all of the time. But again, I think the issue here is that we saw a workforce that, despite professional degrees and licensure, that half of them could not even self-report on an anonymous survey that they had the skills, the training, or the supports to do the work. And so we believe this was one of those opportunities where it's really a win-win. I remember a meeting where I was myself cautious because the CEO, not of the contract, but of the entire enterprise, responsible for 5,000 employees nationwide, a publicly traded company, was in the room. And I was talking about the number of staff we had trained, the surveys we had done, some of the process improvements we had made. And Renee Lehrer, at the time, the CEO of Magellan Health, said, I don't want to hear any more about process. Are we saving more lives? So it's not an either or question, it's a both and. But ultimately, our responsibility was to keep people safe. I've co-led this Zero Suicide Initiative in the U.S. with Dr. Michael Hogan, really grandfather of mental health in many ways, a longtime state mental health commissioner, the chairman of the President's New Freedom Commission report on mental health. And he's made the statement that we have got to work for suicide to be a never event in our care. And at the end of the day, we at the health plan were responsible for services in partnership with the state, with providers, and with the clinical staff that work for them. We could no longer accept the sort of the myth that suicide is a natural course of many of these diseases. We had to take ownership for our backyard, and we had to provide care better.
So you used the phrase never event. What did you mean by that?
So never event really comes from the quality field. I had the opportunity to briefly meet Dr. Don Berwick after a presentation he gave several years ago at a National Council conference. He was the architect behind Crossing the Quality Chasm, the leader for the Institute for Healthcare Improvement, and went on to become, for a time, the leader of the Medicaid and Medicare system in the United States. And I asked Dr. Berwick, wow, I bet you're not aware of the dramatic impact you've had on suicide prevention from your work of bringing quality to healthcare. And he said, oh no, I'm absolutely aware of what Dr. Ed and Dr. Justin Coffey have done at the Henry Ford Health System. And the thing that struck me the most is he, within a very natural and quick way, moved from talking about suicide prevention to talking about hand washing. And I've referenced this story to people over the course of time about what that meant. And it's hard for most folks to get their brains around it. But this is what I took from it, is to Dr. Berwick, suicide was not a problem in a box off by itself. It was like other complex, intractable, challenging issues that human beings have tackled. And hand washing is one of the major interventions that have been done to address hospital-acquired infections. If we go back 15, 20 years ago, especially before the Institute for Healthcare Improvement started the Saving 100,000 Lives campaign, we will find that a view that they were just going to happen. When you put a lot of sick people together in a building, there are going to be infections and you can't do anything about it. Well, that's not the approach that the Institute for Healthcare Improvement took. They said, let's save lives. Let's look at what the data suggests are the major ways people die in healthcare. And hospital-acquired infections was one of the top ones. They began to then compile data and use quality initiative techniques and practices, robust performance improvement, big data, standardized protocols to begin to tackle it. So for him, he didn't see suicide as this inevitable consequence of a disease. He saw it as a challenge that we needed to face with the most robust quality improvement. Now, quality improvement is not something that started, in the last decade. This is a 70, 75-year-old, that goes all the way back to the 50s with Deming, that has been perfected by companies like Motorola and Toyota, but also is being used in healthcare all of the time for inpatient falls, medication errors, wrong patient, wrong site surgeries. So Never Event is about us beginning to address suicide with the same way. Now, I was in the UK a couple of years ago, and one of the international leaders of suicide prevention said, wow, here's another one of those zero tolerance movements. And I said, not zero tolerance. This is really around the opposite. We're not about creating more stress for clinicians. I think what you're hearing from us, Jonathan, is I'm a clinician, and I'm really focused on how do we equip people to be in a better place. We love what we do. How do we do it better? And what I said to him is, I wish we were really pioneers and innovators, but all we're really doing is, and I referenced that I had been on one of those big red buses the day previous in London, riding around with Dr. Jerry Reed, who's a national leader in suicide prevention in the U.S. And he and I took a picture of a construction site with a gigantic crane and this huge banner that said, all harm is preventable. And it had a big diamond in the middle. It said, target zero. So perfect care, perfect processes, never events, target zero. All of these are, instead of us incrementally improving from where we are, let's do the opposite. Let's think about from the other end. If we go to where we want to be, what would that look like? And it's really the same kind of work, but it presses us to think harder, to think more creatively, and to tackle this in a much more focused way. So I think those efforts of calling it out and owning it is how we're going to really change this from something where we accept, at the end of the day, other diseases that people have tackled, heart disease, cancer, HIV and AIDS, leukemia, those diseases, if you look at where their peak was, all of them have made reductions from the height of 25%, as in the case of HIV or AIDS, as all the way up to 75% as it relates to ALL. Suicide is either flat or slightly rising in the U.S. And I think the reality is, as a country, if we go back 5 years ago, it's not fair to say we even dabbled in it. The people doing that work were doing heroic work. But at the end of the day, our society was not engaging the resources, the supports, or the quality improvement to tackle it. And that's what we're talking about with Never Event is, what if you and I, traveling back from here, were on an airline that promised 98 out of 100 safe flights? Or a hospital that said, no more than one baby a month is going to be that we can't really find where it went. Or mail that, 99% of the time it's going to go to the right person. Aviation has brought us a level of safety. I mean, even in our lifetime, I remember when you were anxious getting on a plane. And when that flight clipped the runway in San Francisco year and a half ago now, and 3 individuals died, it was the first time in 13 years that we had had a fatality on a commercial airline in the United States despite 30,000 flights a day. They did that from saying, we want a never event. Now, you have to do that in the context of a just culture. Henry Ford Health System talks a lot about a just culture where it isn't blame when near misses or fatal outcomes occur. But it is everybody learning together as a team using, and when somebody learns in that environment, it cascades throughout the organization. And when something happens or a near miss occurs, we are learning from it because we're owning this together. That's what we mean by never event.
So all the things that you've been talking about, quality improvement and provider education and all that sort of, is that what you mean by zero suicide?
Yes, absolutely. So stated simply, zero suicide is a focus by healthcare organizations to bring a central bullseye to this issue. Forbes magazine back in 2010 did an article, The Forgotten Patient. And on the cover, they had a microscope table with the light shining down. The love, the best practice, the clinical soul, if you will, was shining on this group of individuals. And those are the individuals who are receiving care for depression, anxiety, addiction, serious mental illness, etc. And out on the edge of the table, not off, but sitting with their feet draped over the edge, well outside of the light, was the person who mentioned the word suicide. And their scathing critique was for the entirety of the mental health and addiction system in the U.S., researchers, pharmacology, providers, etc. So this is about, the person at the bullseye and the core of our care ought to be the person most at risk with suicide. Now, I've focused on the organizational, the quality improvement, the data, the bringing a learning environment together. There is a clinical heart to this as well that says that that suicide is inevitable for some people is a myth, and that collaboratively we can keep people safe. Tragedies do occur, like they do with auto accidents. When auto accidents occur, they're needless, they're preventable, and we are constantly as a society working together. And actually, I think we can start to see it in our own lifetimes. We're probably going to reach a time when deaths by car accident are almost never, like we see in aviation. That's coming, and we've made huge gains. So there's a clinical belief that can occur with suicide as well. One of the seminal moments in this national movement was a task force that Dr. Mike Hogan and I led with consensus experts from across the country. We were on a phone call with Dr. Ed Coffey from Henry Ford, and he was talking about how their Perfect Depression Care Initiative movement started, which over the course of time, they saw the suicide rate reduce dramatically among those that they were responsible for, even with several quarters of zero deaths occurring. And in that story, they were applying for an Institute for Healthcare Improvement grant, which they made the finals on, and Dr. Don Berwick came out and explained to them what they were doing was probably very revolutionary for mental health, but was not going to cut it in the context of the never-event environment they were looking for, and perfect care. And so Ed Coffey and his team went back to the drawing board, and they were a little bit just, oh my goodness, how did we so mess this up? And what is he looking for? And a nurse, just speaking, sort of brainstorming out loud, said, well, I don't know. I guess perfect care. I guess that would mean that perfect depression care would mean nobody would die by suicide. A physician in the room stood to his feet and said, that is the damn dumbest idea I've ever heard. If a person is intent on killing themselves, they are going to kill themselves. And then there was this little sort of war that went on within Henry Ford for a moment about clinically which of those two ideas was going to dominate. And they went with the nurse.
I love that for so many reasons.
And that was the trajectory that they went forward with. They weren't saddled with an idea that this is inevitable for some. Harkening back to the U.S. Air Force's initiative in the late 90s, where they saw a 30+% reduction in suicide deaths, that those individuals that were leading that program actually bypassed the clinicians because they were fearful that the myths of clinicians would sabotage the work they were trying to do. So there's a clinical component to this as well. We don't believe suicide is a choice. We believe people succumb when their strength, their resources, their supports, and their hope utterly fails. And we've got to do better collaborating, engaging with them in a learning environment to tackle what is a wicked problem. But humans tackle wicked problems all the time, and we make gains. We ought to do that here.
So why only in healthcare?
So, Jonathan, if I was in another industry, I'd be telling you about that industry. And there are zero suicide-like initiatives. Jorgen Gillenstrup with Mates in Construction in Australia, they are tackling with a very similar approach for individuals who are in the construction industry, where there are high rates of suicide. I started this initiative with partners at Magellan Health in Phoenix, Arizona, because we were healthcare executives. And at the end of the day, think about it this way. We historically have had an approach. Before the U.S. Air Force initiative, there was very little to show actual progress with suicide deaths. And I think that's partially because we were looking at the entire population with a very rare event, and we just couldn't get our arms around it. And what they did was they narrowed down a defined population, began to use interventions. They took responsibility for their backyard. Now, the Golden Gate Bridge for 70-plus years has been a place where there were lives saved. Kevin Briggs and a host of trained law enforcement were supportive of individuals on that bridge, and they saved lives. There are telephones, crisis phones on that bridge, and yet it was also an unsafe place where usually about twice a month someone would die. And that occurred year over year over year to be one of the most unsafe places we've had. And the view of San Francisco and the Golden Gate Bridge Authority for most of that time was, this is something we can do something about it. We're making a difference. But at the end of the day, if someone's going to kill themselves, they're going to kill themselves. If we stop them here, they'll go someplace else. They'll go to the Bay Bridge, or they'll do something different. They'll take a different method. And all that changed after the movie The Bridge came out. And it showed the impact of deaths. It showed an interview with Kevin Hines, who survived a fall from the Golden Gate Bridge. And they made a decision, okay, not enough. No more half measures. We need to fully take responsibility for this bridge. Yes, at the end of the day, our business is, number one, transportation. Number two, tourism. We didn't want to be in the suicide prevention business, but we're going to have to be. We're going to make that a core priority for us, and we're going to undergird the entirety of this bridge, the whole thing, with a plastic-coated steel safety net, which is essentially going to drive that number to zero for our bridge. We're going to do what the Empire State Building and others have done. They took responsibility. They don't own the Bay Bridge. They took responsibility for theirs. And what we did in our health plan contract is we began to tackle this. And then we ran into Henry Ford Health System, and we saw what could be done. And so healthcare, especially any system in the United States or worldwide that is delivering mental health and or addiction services, is working with individuals who face a risk 12 to 15 times higher than the general population. We've seen suicide as an essential part of the disease of schizophrenia or bipolar disorder, of major depression, of individuals who have borderline personality or those with eating disorders. At the end of the day, in addition to that, and maybe even more fundamentally, these individuals are not unlike all the others at risk we're talking about. They're diagnosed with a disease, and they see a path for themselves in life They don't feel like they're going to make a contribution to society. They feel like a burden to others. They become disengaged. They are facing the risk of suicide for the same types of reasons that older white males or LGBT youth or others are facing. And so we believe there's a paramount responsibility for healthcare to own this. So this isn't about only in healthcare. It's about that healthcare must take on that mantle. We must shine that light on this as a bullseye target and own that. Should construction do it? Should universities? The JED Foundation is doing similar work with universities. But healthcare's got to do that too. And that's where we're starting, because that's who we are.
If I were to be looking at leaders in organizations that are implementing zero suicide, how would I know that I'm looking at a leader that was doing it right?
The leaders that inspire me are real people. They're like Becky Stoll, who leads the Zero Suicide Initiative at Centerstone, one of the largest community mental health centers in the United States. The passion and clinical savvy that she has been able to bring to this in activating her workforce. Verna Little at the Institute for Family Health in New York, a series of 29 plus federally qualified health centers, and the way that she has utilize their Epic electronic health record platform to integrate and bake in clinical protocols that are being used across the organization. Leadership like Jan Mockenstorm, who has imported some of these ideas into Amsterdam at 113 Online and in Haste, which is one of the largest community mental health providers in the Netherlands, of making that cultural interpretation, and he's really begun to enhance our view around a mindset, a new culture around zero suicide. And people like Dr. Julie Goldstein-Grummett from the Suicide Prevention Resource Center, who has been a major architect behind a national learning community for zero suicide, and a website at zerosuicide.com, which has a fidelity toolkit and resources. I think those are the real examples of the leaders of this movement, and it's growing.
So you've mentioned so many benefits of zero suicide, everything from the most obvious, which is suicide being a never event, to supporting clinicians, leaders in healthcare. But in any initiative, there are risks. So what are the risks of a zero suicide initiative?
Yeah. I'm not sure I would call it a risk, a weakness, but I tell you one of the challenges that we've faced. I give presentations about the initiative around the country, and it's not uncommon that in the presentation I have a kind of a multi-choice question of, is suicide preventable? And everybody basically believes yes to that answer, but what they mean by that varies. From the lowest level being yes in some cases, to in every case up until the last moment of life. And it's not uncommon for a mother or a father or a family member to come to me afterward and say, really love what you're trying to do, but could you just not say it's preventable every time?
Because it's a tough thing to hear if you've lost someone to suicide. This was preventable. Not just even this was preventable and your healthcare providers didn't do enough, but there's the personalization, which is, and you, the loved one, could have done something else.
Yeah. I mean, the bottom line is these are tragic deaths. If some suicides were inevitable, they would be tragic. But what if they're not? Kevin Hines talks about that last 5 seconds at the Golden Gate Bridge. The 1 second when he's on the bridge and he'd do anything to end his pain. And the next second where he's in the air and he would, wait a second, I would do anything to be back on that bridge. I think if we look back at the 1,500 people plus that have died there, that was the experience of all of them. That makes looking back actually in some ways feel more tragic. And yet the hope of us being able to save lives going forward. So, what I say to family members is, wow, it is the last thing I want to do to heap more guilt on someone. But I think in healthcare, we've had this blanket around us to try to keep us warm from this idea. And that blanket said that some of these deaths were just going to happen. As we've surveyed clinicians about after an event has occurred, being blamed is not an uncommon event that occurs in organizations that don't have a just culture and don't have a zero suicide initiative. But maybe even more frequently what happens is they are patted on the head and they are told, look, this was going to happen. There's nothing really for us to learn about it. We just need to keep going and doing our work. And at the end of the day, when we're part of something bad that happens, the family wants that something good comes of that we learned something, that we incorporated in, that benefited others going forward. So we've included family members in our steering committees and our leadership of this, but it's still a challenge for people who the idea that suicide was inevitable for some is some part of the comfort that they have had. I don't know how to get around that. Now there are also family members who are thankful that we are working to create a new healthcare system that takes this challenge on, but it's hard.
So that was a great illustration of a challenge around the concept of zero suicide. And what would be a challenge for an organization around the zero suicide initiative?
Yeah. When we first started the initiative in Phoenix at Magellan Health, I invited the CEOs of the top largest 10 organizations, organizations like Taros, Southwest Behavioral Health, and others to come together. And the CEOs, as we talked about the clinical rationale and the hope and possibility, they got that fire quickly. But the next round of people that I landed up sitting down with were chief operations officers, people who were beginning to think about the time, energy, risks, etc. And I'm such a believer in this. I don't think there are anything but upsides to equipping your staff around something as powerful as, again, hearkening back to that social worker who couldn't eat, couldn't sleep from doing this work. I think the impact and the discussions we would have with those chief operations officers had to do with the retention of staff, the being a great place to work. And we had to put ROI to those types of
return on investment.
We had to put return on investment to those initiatives, because I'm not saying the chief operations officers were robots with no inner soul that I could touch with that fire, but I had to go through the process of answering their programmatic, financial, HR questions. And again, think about a workforce, 50% of whom cannot just agree, not talking about strongly agree, just simply agree to a question, I'm equipped to do work with individuals that I'm going to face almost on a daily basis. So I think the upsides from a programmatic, from a financial, from a clinical one here at multiple levels in the system are enormous. And we've created a society where we're afraid of this topic. One other challenge is I think there will be positive gains that occur immediately, but the real outcomes that Henry Ford Health System saw took 7-8 years to get to. This requires a multi-year commitment. And Henry Ford with Dr. Ed Coffey and Dr. Justin Coffey being there for 15 years, being able to perfect and improve and take this, and then having the luck that when they left and went to Menninger and Dr. Brian Amadani took over at Henry Ford, that he is fully behind it and driving it forward. The Henry Ford Health System has made a multi-year commitment and long-term focus on a central bullseye effort here. That organizations have to be willing to accept. It's not going to happen overnight.
Which I know is a huge challenge in social services, in healthcare. You have things that are on 3-year grants, 2-year grants that are the brainchild of one person, and then they leave, and then it's gone. And you're saying zero suicide, while it might have some benefits in the short term, it's really, we're looking at the long game.
Absolutely. The investments that are made, the changes that are going to occur in culture, and in baking in protocols, in supporting staff and learning together. Now, I think Henry Ford operated in somewhat of a vacuum. We're starting to see a national and even international learning environment occur where people can support one another. And I'm hopeful that will mitigate some of that challenge we just talked about.
It sounds like zero suicide is not just a U.S. thing. So where is it happening?
I referenced earlier the meeting in Oxford a few years ago. Last September in Atlanta, we brought together the second international gathering of zero suicide. And we had representatives, about 50 policymakers, healthcare leaders, family members, people with lived experience and expertise from 13 countries. 50 individuals come together. And the pioneers that are out there right now, the ones that are the most established, there are 3 initiatives in the UK, in Southwest England, in Liverpool, in Cambridgeshire, and Peterborough. There's also an initiative that looks like it's going to be launched in the Yorkshire area. So there's a number of initiatives from the UK. Again, I referenced Dr. Jan Mockenstorm and his group in Amsterdam within HASTE, and then Dr. Steve Duffy in Christchurch, New Zealand at Hal Morton Hospital has been looking at developing a similar program after visiting with Henry Ford and a number of folks in the U.S. So we are seeing this cascade. One of the things we did at the International Summit last September was we had Professor Jo Smith. She is one of the pioneers behind early intervention services for first break psychosis. And we're seeing a worldwide phenomenon around early intervention services now. But that really began with a small group of pioneers back, over a decade ago. And they used an international declaration as a platform for that of again, think never event, blue skying what could be. And they pirated that idea from a group of diabetes pioneers of co-management from 10 years earlier than them, when the idea of the person owning their care didn't exist. And again, blue skying what could be. So she came, facilitated, and we have this document, the International Declaration for Better Healthcare, that's available for download at zerosuicide.org. But we're hoping that this becomes the basis for continuing to see this initiative expand into the other countries that were a part of that summit.
So, David, I really appreciate you spending all the time to talk with us. This has been really inspiring and encouraging. For those who are listening to this right now and are thinking, wait a minute, I want to do this. What are the next steps for starting a zero suicide initiative?
Thank you so much, Jonathan, for the opportunity. So Zero Suicide is an organizational effort. It's a strong component of leadership, but the seeds of all that are planted with individuals. So I think the first step, I'm a clinician, you're a clinician, the first step is to make a personal commitment to this. I made a personal commitment that night when I got that phone call that I was going to figure that out. It seemed to me to somehow I knew that went to the heart of being a clinician. And so that's where this is going to grow into the leadership. The second thing is organizations, in order to do this, have to establish steering committees to make it happen. That multi-year commitment we talked about, the changes in culture and mindset, the efforts and activities that are going to have to be in place to support staff to do what they love and do it better, requires a group that's going to own that, that's going to develop an implementation work plan. And the resources I mentioned earlier, the International Declaration, as well as the work that the Suicide Prevention Resource Center has done, and the tools and resources at zerosuicide.com. Dr. Julie Goldstein-Grummett leads a learning community on a monthly basis. They have a national listserv, so a steering committee. And that steering committee, it ought to have clinicians in it. It ought to have leadership in it. It ought to have some outside folks. And the magic isn't really going to occur unless there are people with lived experience of suicide on it. And not just family members or people who've had someone die. We're talking about people with personal experience of they've made a serious suicide attempt and they want to now translate that into helping others. That's going to make that steering committee differently. And then the third and final thing is this is a social movement. This is more than a healthcare initiative. It's more more than robust quality improvement. If you track out in the Twitter sphere the hashtag Zero Suicide, it's spreading worldwide, and there is an ownership of it from not only clinical and healthcare leaders, but again, people with their own life expertise that is forging new ground.
Great. Well, thank you so much.
Thank you so much, Jonathan.
Hey, it's me again. Did you like this episode? It was awesome, right? So, quick reminder, fill out this survey, leave a review on iTunes, and let me know if you want to transcribe an episode. Thanks. Okay, here's the klezmer music.
I'm Jonathan Singer, and thanks for being with me today for another episode of the Social Work Podcast. If you missed an episode or have suggestions for future episodes, please visit socialworkpodcast.com. If you'd like to support the podcast, please visit our online store at cafepress.com/swpodcast. To all the social workers out there, keep up the good work. We'll see you next time at the Social Work Podcast.